I'd like to introduce Dr. Jennifer Green. Now, Dr. Green's had extensive involvement with the RACs and has contributed widely, not just to RACs and to the community. So I'd really like to sort of go through an introduction with her, for her. Dr. Green is a hand and wrist surgeon in Canberra. On completing orthopaedic training in New South Wales, she undertook hand fellowships in Indiana Hand Centre in the US and the Institut de la Main in Paris. Jennifer has practiced in Sydney, Brisbane and Canberra, and courtesy of a military spouse who all know tend to move quite frequently. Jennifer is a member of the OPOA Hand and Upper Limb Committee, the AHSS representative to the APFSSH Council, and a member of the AOA Cultural Inclusion and Champion of Change working groups. She's the founder of the International Orthopaedic Diversity Alliance. This is a collaborative group to increase the inclusion of women, underrepresented minorities in orthopaedics, and is passionate about diversity in orthopaedics. Jennifer is immediate past chair of the AOA Orthopaedic Women's Link Committee and has had roles in the RACS Women in Surgery Committee, ACT RACS Committee, and the AOA ACT State Committee. She has been the AOA representative to the Diversity Council of Australia and the AHSS representative to the Australian Ethical Healthcare Alliance. So I'd really like to invite and welcome Jennifer to talk to us today. Jennifer, you might just, might just have to unmute there.
Thank
Excellent.
You for the kind introduction. And I will just start my slideshow. So thanks for summarising what we're up to. I just wanted to take this opportunity to share some of the lessons that we're learning in orthopaedics as the world's least diverse specialty, and share some of the options and ideas and initiatives that can help increase diversity, not just for women, but for the many underrepresented minorities, which is very important for Australia as such a multicultural nation. Diversity isn't just something that's good to have, it has lots of practical benefits in our knowledge economy. McKinsey in their landmark paper in 2015 showed that organisations who have more than 30% diversity attract the top talent, they're more innovative, and they make much better decisions. And this has been expanded into medical, legal, and many other fields. So we know that a lack of racial or ethnic diversity in any organisation means that those lived experiences aren't there to speak to social issues that affect our diverse patient population. If we're not including more diverse candidates into our fields, we are missing out on some of the best and brightest. And we also risk losing our relevance as an organisation, also our reputation. And probably more important than all the organisational issues is that a lack of diversity in our health workforce just continues to promote healthcare inequities. Christy Webber was a immediate past president of the American Academy, and she speaks to the critical assumptions we should have that people have equal rights regardless of their differences, and all applicants who can meet or exceed the criteria for selection should be equally recruited because they have the potential to become competent surgeons. Increasingly, universities are using this distance travel model in selection, acknowledging that some candidates have had enormous obstacles to overcome, that academic achievement is really related very much to our privilege, and that we can support disadvantaged candidates through training. In orthopaedics, there are hundreds of papers now on disparities in both gender and race in orthopaedics because of our lack of diversity. There are higher amputation rates in ethnically diverse communities. There is less access and higher complication rates in knee arthroplasty. And a lot of the issues have to do with communication and lack of trust in people that don't look like yourself. For those who are a bit cynical about the value of diversity, this paper on births in Florida analysed 1.8 million hospital births. They found that black babies died at 3 times the rate of white babies. And black babies were more than twice as likely to die in the first year, regardless of the mother's income and regardless of her education. But when a black doctor cared for black babies, the mortality rate reduced by 50%. So diversity is important. It can be like a life or death issue. We know that things are not really great for gender equity. The World Economic Forum said it would be 208 years to reach gender equity in the US, and we can assume that Australia is very close. We have, as the International Orthopaedic Diversity Alliance, collected a large volume of data on women in orthopaedics, and not a single nation reaches the 30%. Those who are best, such as Estonia and the Scandinavian nations near to them, have excellent social supports. They have the best supports for children who are for parents who are working, and also parental leave opportunities way in advance of many others. And this is part of the reason they have such large engagement of women in orthopaedics. We've also sought information through the European societies that show that overall European societies are doing better, but there are still many, many nations who don't even reach 10% of women in orthopaedics. We know that from studies on gender and healthcare, that one study from Canada, a nation quite similar to us, showed that a male patient was almost more than 20 times more likely to be offered a knee replacement when he presented with the same symptoms and x-rays, and that the underuse of arthroplasty is a problem in the US, but it's more than 3 times as bad in women. So there is a significant healthcare inequity. We know that women make good doctors. There is evidence shows that the patients of female internists die less frequently, and the patients of female surgeons have slightly fewer complications. So the role of women in medicine is not questioned. This graph, however, shows a lot of the problems. This is 10 years of the pass rate at the American Board of Surgery exams. And you can see that whether you're married, partnered, or married with children, as a male, this has almost no effect on your results and your pass rate. In fact, you do better off when you're partnered and have children, whereas for women, this effect is quite profound, dropping substantially when you partner and much more when you have children. So there is a role here for changing things and addressing some of these barriers to diversity, the lack of visible role models, the lack of flexibility in training, unconscious bias in reporting and promotion within our organisations, and lack of mentorship and sponsorship. This photo to the right is on the front page of the Courier Mail, featuring orthopaedic surgeons. So we have a lot of visible role models now in orthopaedics. We know that early exposure is important. We are running workshops for women to expose them to opportunities to talk and try orthopaedics. We are mitigating unconscious bias in our selection process, in our promotional process. We have policies for inclusion in women in scientific meetings at AOA. And there is a lot of diversity, education and discussion. We have a very committed and visible leadership. Our training's now competency, not flexibility, not time-based. We have breastfeeding and childcare facilities at all our meetings, available at all our meetings, and all hospitals who have 3 or more trainees have to be able to show that they can host a flexible training post. So mentorship and sponsorship we know is important. We have a lot of other organisations around the world who are supporting diversity, and we are linking together on a larger scale. We have pipeline programs across the US, and we are emulating them here in Australia. There is more discussion about LGBTQI now in orthopaedics in the US, and this is extending internationally. We have a large number of women in orthopaedic who will be leading orthopaedic associations in the next 2 years from Australia, Britain, the UK, the US, and in Europe. As mentioned, we're an international collaboration. We have members across the world. We're sharing evidence-based insights. You're welcome as non-orthopaedic members to join us. We have an enormous diversity library that's accessible to members, and a lot of webinars and also podcasts to educate people. And we're publishing articles and collaborating with a number of organisations and presenting about diversity at all the large international orthopaedic meetings, and including SICOT, who have they're the International Society for Orthopaedics. So in summary, diverse organisations attract the top talent, they increase innovation and make better decisions. And the pathway to diversity is visible role models, minimising unconscious bias, increasing flexibility, and of course, mentorship and sponsorship. We need diversity in surgery to improve equity in healthcare so that we can remove the barriers completely. Thank you. You're muted, David.
Sorry, I've been doing the same thing. Jennifer, thank you very much. That was absolutely fascinating. You know, I suppose with the organisations, the skills, we're sort of trying to encourage people at the beginning of their surgical training years. What capacity has the RACs got to look at trying to encourage students at medical school, but even before that, you know, at high school, at pre-graduate levels, you know, because, you know, cementing that role model at an earlier age, do we have the capacity to do that?
Yes, I don't know if you're aware of it, David, but one of our urology colleagues in South Australia has just actually published a book for toddlers about becoming a surgeon. So that we can start there.
They might be getting a bit early, but...
so I could send you some details about that. But yes, we need to start really early. Colleagues of ours have daughters who have been told in high school that orthopaedics is not for women. So it is not just, it's not coming from within orthopaedics mostly. A lot of this is coming from outside, and we need, yes, we need to get into universities, but to get into medical schools requires us to go to schools and be involved in our communities and pass this message around, and I would encourage everyone to do that. Absolutely.
So I've just had a question from Florence New. It's not coming up, but look, Florence has said, you know, Florence has mentioned that, you know, she's fascinated to know that, realise the importance of diversity is not just an ideological issue, but actually translate into hard statistics that you'd mentioned. She's interested in to know if that study had finding the lower mortality with Black doctors looking after Black babies, why were there reasons for this? You know, was that explored in any more detail?
No, not that I'm aware of, but there is a lot of evidence suggesting that the issues of communication and the issue of trusting people is an important, is very, very important, and that people of different nationalities will engage in healthcare if they see someone they believe they can trust to look after them. So a lot of the issues, the inequities, because people are afraid or untrusting as well.
I mean, the issue is not unique to orthopaedics. Are there particular subspecialties that have better balance or improving balance more than others?
Everyone except orthopaedics is. Orthopaedics, name one.
Right,
so
okay.
Not that we're aware of, not that I'm aware of. I don't think a lot of that data has been widely collected.
Excellent.
And that is an issue, and we're now trying to engage, because a lot of our societies do not collect data about diversity. We know male, female, but we still haven't explored this, and we're starting to try and gather that information, because unless we know who we are and who our group is, we can't really have goals to improve.
Excellent. Look, Jennifer, thank you very much. I'm really impressed by the ability to drive this topic forward, which is critical, you know, to the survival of RACs in the longer term, I think.
Thank you, David. Thanks for the opportunity.